Hi, Dr. Sugg. How are you?
Hi, Kara. How are you?
I'm doing good. I'm actually connected through audio on my phone with earbuds, so I know it may be a little muffled.
Oh,
And what is the correct? I had a family member that spelled the name the same, but we called her Sugg, and so I
oh,
wanted to make sure I had your last name correct. Is it Sugg?
yes.
S-U-G-G?
Correct.
Okay. All right.
Thank you.
Perfect. Well, I think you're very welcome. I know as a center administrator, I kind of get everything rolling, but Dr. Hahn should be on, and then Dr. Haynes will also be on. And we had hoped to have Dr. Haynes introduce you, but she had a meeting that butted right up against this one. So it's a toss-up right now. If her meeting finishes early, she'll do your introduction. If not, Dr. Hahn, the director, will do it. So we
Okay.
appreciate your time.
Yeah, thanks for having me. Should I test to make
You're
sure
welcome.
everything works? I guess you can't see, can you? So I'll do it.
No, I'm connected to the audio on the phone, but I can see your screen, and I just made you co-host too. That way, if anything were to happen and it shuts down, then you have the ability. But yes, I'm seeing your full slide deck, so
Okay,
and you're
cool.
good. And we do record these. This part is not recorded and shared, but I clip both the front and the back, and then post it on our YouTube page too. So
Oh, awesome.
yes, looks good.
Thank
Those
you.
are beautiful graphics on your slides.
Oh, good. So you can see it okay right now. So
Yes,
cool.
looks perfect. Yeah,
I always get
great.
on early
And
just in case. So,
exactly, yes, just to make sure that the tech is working. And we do, you'll see kind of as it starts, we will, everybody goes into a waiting room, and then except for you and Dr. Haynes and Dr. Hahn. And once we get close to noon, then we'll go ahead and admit all, and that just gives us private time to work out any kinks. So
okay, great. Thank you.
you're very welcome. And I just messaged Dr. Hahn as well, just to make sure. We'll have a couple of links to put up in our chat. Just a survey about today's webinar and some of our career development awards and other things that are going. So you'll see some of that also come up in the chat.
Okay, cool.
And as far as your presentation, I know normally you can have anywhere up to 45 minutes. And then we do about 15 minutes for Q&A. And if we can't get to, for any reason, I know we're at the end of the semester here, but if we can't get to all the questions, I do put them and send them to you for follow-up after this session.
Okay, that sounds good. Yeah, I was planning for about 45. I tend to talk
Yeah.
too fast, so probably less than that. So,
That is okay. Well, and if you want to just take a few minutes and mute and turn your camera off, that's other thing before you do that. If you wanted to, we do ask the participants to mute their microphones and turn their cameras off while you're presenting, just so that we don't have any interference. But if they wanted to do it, if there's enough people Q&A and they can behave themselves, they are allowed to turn their mics and their cameras on. So
okay, great. Yeah, I might grab some water real fast if that's okay. So
that sounds perfect. I'll just go on mute and I'll wait for Dr. On.
thank you.
Welcome.
Hi, Maggie.
Hi,
Hi, nice to meet you.
nice to meet you too. Thanks for having me.
Yeah, so I know you, I think you probably talked to Erin Haynes, but I'm the director and of the UK Care Center, and I can't wait to hear your talk. We have a lot of people who are interested in climate and health and for kind of in a new way. So we were excited to see all the work you've been doing. So I think we'll probably have a pretty good group. And so thank you for saying yes.
Of course, yeah, it's great. And you guys are in the Appalachian Mountains too, so it works out really.
Yeah, well, we serve the Lexington sits in central Kentucky, so we kind of butt up against Appalachia, but I was actually born and raised in Pennsylvania in the Appalachian chain. So I have a special interest and love in Appalachia, and particularly rural Appalachia. And a lot of my research is in rural Appalachia, and a lot of the work we do is in our service area, which is actually Southeast Kentucky. We call it the boot of Kentucky, but it's the Big Sandy, the Kentucky River, and the Cumberland Valley District. About 21 counties in Southeast Kentucky is our service area for our center. So
Yeah, that's great. Yeah, definitely, I'm not going to talk about it today, but yeah, we're definitely in the rural Appalachian Mountains too.
Yeah, so if maybe we can find some ways to collaborate. I would love to. So it was great that we found you, and I think Erin found you actually, Erin Haynes.
Yeah, she did.
Yeah, have you talked to Erin
much?
much?
Yeah, I talked to her at the beginning of the semester. And yeah, she was great. Yeah, and this is a great opportunity for me too. Because I'm in an undergraduate institution. So
yeah, right. So if we can get you engaged with the researchers at UK, that'd be great. We also have a really strong community component. All of the P30 centers around the country have to have community engagement components to their centers. So we have a really strong community engaged research group, as well as people, on our advisory board in the community. So we may very well have, thanks, Kara. We may very well have community members on the group, but it looks like people are kind of slow to jump on. So only a few people in the waiting room, 4 of them. Oh, okay. Well, let's give it another minute, probably, Kara. And I know that Erin was going to introduce Maggie, but I certainly can. But when Erin gets back on, or hopefully she'll get on because she has another meeting right up until noon, and she may have to run and get her lunch, but I think she agreed to lead the question and answer. So as people jump on, I just want to tell you, oh, good, there's 8 now, or maybe a few more. We have what happens typically is that this is lunchtime, obviously, for us. So people turn their cameras off, they eat lunch, but that doesn't mean they're not listening. And then when it's question and answer time, we typically ask people to unmute or, turn their cameras on and ask their questions, but we will keep track of questions in the chat for you.
Okay, thank you.
And you've already tested your slides and you're good, right?
So, yeah, I think it's working great. So. Great.
Well, so Carol, why don't we just go ahead and see what she put. Let everyone in to the event, and we can jump in and start if that's okay.
Sounds good.
All right. Good morning or good afternoon, everyone. Welcome to our environmental health seminar series. I'm Ellen Hahn. I direct our UK Care Center, a Center for Appalachian Research and Environmental Sciences. Just wanted to give it a minute to see if Erin Haynes jumps on, but if not, I am so excited to introduce our speaker for today. I do want to also just give a couple commercials about our center. We have lots going on right now. We have a portal so that if you're a member of our center and you need assistance with any part of the research process, please know that you can jump on our portal and request services. Also a career engagement or career development call for career development right now. Kara Richardson will put in the chat during this hour all of the many things that are available to you as a member. So without further ado, I will go ahead and introduce Dr. Maggie Sugg. Maggie is an associate professor in the Department of Geography and Planning at Appalachian State University. Maggie focuses her research on spatial temporal patterns of environmental health and illness and how these patterns relate to environmental, socioeconomic, and climate change. Dr. Sugg is a recipient of a National Science Foundation Career Award. Congratulations on that. And the EPA's Star Fellowship in Public Health. She also has funding from EHS, which also funds our center, as well as the American Foundation for Suicide Prevention. So she will be talking to us about causal analysis of the complex mental health impacts of climate and disaster among youth and adolescents. So happy you're here, Maggie. Take it away.
Yeah, thank you, Dr. Hahn, for the nice introduction. And thank you all for bearing with me through your lunchtime. I appreciate it. I'm also in the Appalachian Mountains. I know your center serves that at Appalachian State University. Hopefully some of the things I talk about today could be kind of a stepping stone for potential collaboration. Today, I'll be focusing on kind of mostly our NIH grant. So looking at the impacts of climate disasters and mental health among youth, but also touch on some of the career work, NSF career work, which looks at the geography of mental health. So hopefully you're seeing my slides okay, but yes, to kind of give you some context for the significance of this problem, mental health is a significant contributor to the global disease burden. Nearly 1/4 of people worldwide will develop a mental health disorder in their life. Most of these occur in early childhood, adolescence, as well as among young adults. And as I'm sure you're well aware, suicide is the leading cause of death in the US. In 2020 alone, there was also 1.20 million suicide attempts. So it's definitely an ongoing crisis. Because of this continuing increases in suicide and suicide attempts, and along with the COVID pandemic, the Surgeon General did the unprecedented task of issuing an advisory in 2021, really calling attention to youth and adolescent mental health and all the different factors that can affect youth and adolescent mental health. He really addressed the need that there's a national crisis, and due to this national crisis, we need really multidisciplinary perspectives and approaches to address it, and more novel digital data sources and interventions to kind of reach this population. And so this is kind of where our research fits in, and I'll talk about that as well. And so our perspective takes mental health and youth mental health and considers it from a climate change angle. Impacts of climate change and health are well established. Prior to the pandemic, this was considered one of the defining public health issues for the 21st century. The impacts of climate change have been pretty well established, and there's been lots of different research. A lot of my prior research looked at heat-related illness and the effects of temperature, a lot of air pollution research, water quality, degradation, but there's still, lots of research gaps when we consider some of the mental health implications of some of these severe weather events. And to me, climate change, is a threat multiplier. It takes these already existing disparities that we see in Appalachia and other regions across the US and enhances those disparities. So those people with already existing mental health problems, it can enhance them, can cause new ones. It's definitely enhancing these already disparities that we see a lot in public health. And then among pediatric and child populations, this population is often more impacted by disasters, climate disasters, and they're more likely to have continued trauma-related symptoms after disaster. Yet little is still known about this population. There's still a lot of new research that's needed to understand what the consequences of some of these disasters are for the specific subpopulation. And so from our perspective and from some of our NIH funding, what we're really interested in is how we can fill the unmet needs and gaps for this population, particularly among youth. We feel that, crisis hotlines have been shown in the literature to reduce feelings of hopelessness and crisis and attempts of suicide. Yet these hotlines themselves are underutilized among youth. Text messaging is the dominant form of communication. And so text-based crisis interventions they've been gaining a ton of popularity, and they're kind of a great intervention for this population. And this is where we're getting some of our data for our analysis. Yeah, so our data is what we're using one of these crisis text-based messaging platforms as our source of data. The main one we're using is Crisis Text Line. So this is a really large nonprofit that was started in 2013. It has national coverage as well as coverage in Canada, in the UK, and Ireland. It's huge. So it's really commonly used among adolescents. Over 85% of the conversations are for those under age 24. And what it is it's a text-based platform. So youth are texting in and being paired with a crisis counselor. So far, with our latest data set, approximately 80,000 people had used it, again, mostly adolescents. And this has resulted in over 8.5 million conversations. And so we're leveraging this data set, which Crisis Text Line sometimes promotes as the largest mental health repository nationally or worldwide. We've been using it for several publications, and I'm kind of going to give you like a survey overview of some of our publications we've used with this data set. And so Crisis Text Line, it's text-based and it's also volunteer-based. So there's lots of crisis counselors. These crisis counselors are supervised by a clinician. They kind of have a network of them. And the crisis counselors go through a training process. When they agree to do the training process, they commit to over 200 hours of volunteer time. After each of these crisis events, after this text-based conversations, crisis counselors will code the different topics. And so these different topics for the conversation can range from depression to suicidal thoughts, bereavement. And then, so they follow up each of these conversations with the tagging of the different crisis outcome. And some of the outcomes we've been using, we have some that are like normal risk, depression, isolation, abuse, anxiety, stress. And then we have there's a triage system too. Those texters with suicidal thoughts or self-harm, and those with like a manner, so a capacity, those get triaged as more high risk. And so we can see how these outcomes, and you can also track texters throughout time, those who repeat the service. Along with information about the different crisis outcomes, we also, for 25% approximately, a little bit under 30, some texters will also fill out demographic information. They have an optional survey at the end. And from this survey, we can get really rich information about the people using this service. We can get their age, their gender identity. We can get gender nonconforming, female, male, race and ethnicity, as well as other specific questions that we can ask post conversation. And kind of just to preview some of the work we've been doing. So we've published a fair amount with this data source. This is one of our first publications, just looking at usage of crisis text line for suicidal thoughts compared to suicide rates. Obviously, higher suicide in rural areas, although lower usage of this crisis hotline. We've also looked at suicide contagion in the context of different events, like the release of 13 Reasons Why, which was this Netflix series that had a suicide within it, as well as celebrity deaths. And we've noted increases in usage after these events. During the pandemic, we used it to look at other subpopulations. With that survey data, we were able to get information about if a texter was an essential worker or a child of an essential worker or had no relationship to essential workers. We were able to evaluate some trends within the pandemic. I'm a geographer, so I'm going to show you a lot of maps. It's just part of my presentation, but yeah, here's some maps showing that. And then here for your epidemiologists, probably more of a comfortable place, the forest plots. Across the pandemic, we can see this is for workers, compared to non-workers of the same age, we see higher odds of grief, as well as suicide capability. And then children of workers, we see grief, and then we also saw substance abuse increases, and that was particularly for Indigenous populations, and we broke it out further. I'm again a geographer, so I do a lot of clustering spatial techniques, and this is a spatial temporal technique looking at hotspots both in space-time. And this is for bereavement, so looking at textures, crisis events for bereavement. And we can see that they occurred during different time periods of the pandemic, and it closely corresponded to where we saw peaks of COVID-19 with the actual incidence of those cases. And then we've done some latent class analysis too, using this data set, looking at how throughout the pandemic, how youth changed different classes, and looking at the severity of these classes as the pandemic progressed. But that's just a preview of what we've done. What I'm going to talk about today and why you guys invited me was to think about climate and health. We've been doing a lot of work in climate and health, but this particular area that we're focusing on is climate disasters and pediatric mental health. We're interested in the causal association with climate disasters. And we're using this digital data source to try to understand that. And some of the perks of using this digital data source is we can get the information in real time. So a lot of times, with hospital administrative data, the data can lag 1 to 2 years. We can get this data quite quickly, like we're already analyzing Hurricane Ian, which hit Florida just a few months ago. And again, so we're interested in trying to address what is the association with climate and mental health, particularly for adolescents and youth. And I'm going to go through a couple of our papers. I'm probably going to do it pretty quickly, but our first paper that we looked at was Hurricane Florence in 2018. This was a really large storm that hit the Carolinas. It caused massive flooding. And then we're going to look at Hurricane Laura in 2020. This was an interesting storm because it also co-occurred with a lot of other events like the pandemic and the presidential election, so a couple social events as well. And then the wildfires in 2020, I'm going to talk about this in a paper we did related to this. These were also some of the larger climate disasters that occurred within the pandemic. This particular wildfire season was one of the worst on record for California. And then some of our latest analysis that was just published was looking at winter weather storm Uri. And this was that storm that hit Texas in 2021 that caused electrical grid failure. It had a lot of impact, particularly for minority populations or those with lower income. There was a lot of housing damage and longer term impacts even after the severe winter weather. And then finally, kind of using a different methodology, I'll talk about some of the high temperatures and how we're seeing when we look at mental health and high temperatures, what is the relationship we see? How does that vary among data sources and different methodologies? And I'll bring in we also do a lot of work with administrative data, hospital administrative data. I don't have time really to discuss that, but I'll bring in some of that here too. So that's the general flow of what I'll talk about. For most of this analysis, we're using a quasi-experimental design. So we're trying to simulate experimental design as much as possible using the natural experiment of the climate disaster itself. We're predominantly using 2 different methods, an interrupted time series analysis, where the storm or the disaster itself is the natural experiment, and then also a difference in difference analysis. And there's some differences between the 2. Sometimes we use both, or sometimes we just use one. With interrupted time series, we're using an ARIMA model, an autoregressive integrated moving average model. We're using the prior, it's a time series analysis, so we're using the prior time period. And then after the disaster itself, we're forecasting what we would expect to see with crisis outcomes, and then comparing that forecasted amount to the observed and seeing if there's a significant increase or decrease. We also supplemented with difference in difference. Difference in difference, unlike the ITS analysis, allows for the incorporation of a counterfactual or a control region. And so we can compare not only two different, so prior to the event, during the event, exposure, non-exposure during the time period itself, but also regions that were impacted versus not impacted. With difference in difference, you also have to be really careful about parallel trends assumption. You have to make all those assumptions before you can say there's a causal association. And so those are our two main methodologies that we're using to describe these different studies. Here they are here. So here's our interrupted time series. Again, we have multiple measurements, usually at the day we're doing it at the daily level. We're comparing the intervention, which for us is the disaster itself, and then comparing it to afterwards. And the difference in difference, here's a diagram of it here. We're looking at two different locations. We usually define exposure. We've been using FEMA disaster declarations, and then comparing different time periods as well. And again, the data for all this is crisis text line. We've compared it to the census data. It's fairly representative of different demographics. And we have African-American, we have a little bit higher indigenous population, Asian, Hispanic. It also has Spanish speaking capabilities, which is so crisis counselors can communicate in Spanish. And then we have some co-occurring, this didn't show up very well, but we have some co-occurring conditions. And I'm showing that here in this matrix C. One interesting thing about crisis text line 2 is we also have sexual, gender, minority information. And so we can look at this population specifically. I know when you were dealing with ED visits, inpatient, outpatient, hospital administrative data, it can be hard to capture that subpopulation, but we can capture it with this data, which is kind of an innovative way to look at some of these health disparities. So first I'm going to talk about Hurricane Florence. It was one of our first papers. Again, this was a really large $1 billion disaster for the state of North Carolina, where I reside. It caused extensive rainfall across, particularly North Carolina. It was a slow-moving storm, and it was considered, 1 in a 1,000-year event. Upwards of 50 inches of rain in some parts of North Carolina. It dumped about 8 trillion gallons of rain, enough to fill 12 million Olympic swimming pools, and it had a lot of losses. And these losses exceeded some of the big storms that also hit North Carolina, Floyd in 1999 and Matthew in 2016. For us to define exposure, we just used FEMA disaster declarations, and we considered locations that had both individual and public assistance as those that were exposed to the Florence. So these are those disaster declarations. And again, Florence was a really unusual event here for North Carolina. And I know you guys also just had some massive flood events too, so it may be relevant. And so with Florence, we did interrupted time series analysis. So using Florence as the natural experiment. These are our different models. We have during the storm, short-term impact, immediate continuing impact, and delayed continuing impact. For immediately following the storm, we saw a 15% increase in crisis texts for anxiety and stress. We saw a 17% increase in suicidal thoughts during the week of the storm. So text volume for all anxiety and stress increased, as well as for suicide ideation 6 weeks post-storm. And our forecast models showed that for anxiety and stress, that was 2.2 times higher than expected 30 days post-Florence. We can see that here on these plots too. This is the publication. Overall, when we had texters for any reason, we didn't see any significant trend post Florence. But when we look at some of the more severe outcomes like suicidal thoughts, we did see an increase in 23%. So definitely increase there. And anxiety and stress, well, 6 weeks after. And a cool thing we did with Florence, because we have access to the data, is we also work a lot with North Carolina hospital administrative data. So we did the same analysis for ED visits, emergency department visits, using diagnostic codes for adolescents to see if we saw similar trends. And we did see parallel trends for the emergency department visits, which was really exciting for us, considering maybe this digital data source is paralleling what we see with these administrative data. Again, the hospital administrative data takes a long time to access. It also can be very expensive to access too as a researcher. So we found this really encouraging that we're seeing a similar trend for both data sets with Hurricane Florence. Okay, so kind of giving you, again, I'm giving like a survey of all our different work under this NIH grant and NSF career. Another study we looked at was the Western US wildfires in 2020. These wildfires were particularly bad for California. It was considered at the time one of the largest wildfire disasters for that area. Some of the first like mega fires that continuously burned. And then it also occurred, in the beginning stages of the pandemic. And so we were really interested in the effect of the wildfires and how it related to co-occurring events. So a lot of times, we look at a disaster as a univariate event, but what happens when you have a disaster upon a disaster, when they're co-occurring or they're compounding? We're trying to get at trying to figure out if that makes mental health worse, or do we not really see an effect? And again, the objective here was to look at the mental health impacts of concurrent disasters, so the 2020 wildfires, as well as the COVID pandemic. We looked at a 2-month period. Here's our time series right here. And you can already see like where the pandemic occurred. We see upticks in crisis conversations with the start of the pandemic there. And here we have our wildfire locations, which were our exposed locations. And we also did not only a REMA, but a DID, a difference in difference analysis. And we tried to choose control areas within the same state, but it was hard just because of all the wildfires throughout the Western US. But we chose control areas as those without a wildfire with similar age and demographics that met the parallel trends assumption. And overall, these are our REMA models looking at interrupted time series, the forecasted. This is for the wildfire events. We looked at it again 60 days post wildfire. And overall, compared to Florence, we did not see a significant increase in these outcomes. And we saw similar findings. We also did a sensitivity analysis at the state level for California and Oregon, and we saw similar findings. And so with this analysis, we really didn't see an association between wildfire exposure and excessive crisis texts for mental health. We hypothesized that it's likely like the unprecedented pandemic was really what was the main driver in those increases in crisis text outcomes. We also did a separate DID analysis. I'll show those slides later. But yeah, we really, to us, what we hypothesize is that the mental health impacts from the unprecedented pandemic really overshadowed the mental health implications of this wildfire event. This was in the beginning stages of the pandemic. And so we didn't see those. We saw increases, but they were not significant. And that was likely due to the pandemic itself. And then we did a difference in difference analysis, just as a follow-up, trying to find out what's going on here. This difference in difference, we did note decreases in outcomes like depression and suicidal thoughts for wildfire exposed locations. Some of this decreases, we thought perhaps that could be like there's been some literature suggesting there's like a coming together in the early stages after disaster. Perhaps that could be attributed to that. Definitely more research needed about that. Okay, so following up, one of the other disasters we've been looking at is Hurricane Laura in 2020. This impacted the Louisiana area. And also kind of a same time frame. So with that pandemic, kind of like the wildfires. And again, we're kind of interested in this idea of like concurrent disasters, how, these compounding events are occurring more frequently. What does that mean for mental health? And so for this specific study, we wanted to compare how Hurricane Laura, how it compared to some of the other disasters hitting the state of Louisiana. So we focused our analysis on Louisiana. We looked at the COVID pandemic. We looked at the Black Lives Matter protest. We looked at Hurricane Laura, and we looked at the 2020 presidential election. And really, this analysis is still under review, but we were really looking at the short-term impacts. So just a few weeks after each event, what kind of mental health response do we see in the crisis text line data? Just using simple Wilcoxon sum rank tests, we see overall, when we compare it to 2019, increases for the pandemic and Hurricane Laura and the 2020 election. However, when we use our quasi-experimental design, we don't see the same increases. So these are the different models: COVID, A, George Floyd, Black Lives Matter, Hurricane Laura, C and D. We see significant increases. Those are substantial for the COVID-19 national emergency and the 2020 presidential election. Those two events, we saw, pretty large increases. And those increases were also observed for the more severe outcomes, like thoughts of suicide. So of the four events, those were the two more pronounced: the 2020 election and the COVID-19 national emergency. And so to us, we kind of, hypothesize that some of these social stressors are very distinct from the natural events. And among this youth population, we are seeing perhaps those social stressors are more causing greater mental health outcomes than some of these natural events. And this work is still under review. And it was led by a student, Sophie Ryan. Another student-led pub was looking at Hurricane Ida, and this is getting further away from the pandemic itself. Same idea. It was led by Luke Huertas, who's getting his PhD at Maryland. But we examined changes in crisis help-seeking behavior among those in Louisiana exposed to Ida. Getting away from the onset of the early pandemic, we're starting to see more significant increases. We saw more significant increases in crisis texts, particularly for any reason. So anyone calling in for thoughts of suicide, stress and anxiety, and bereavement. And this was for 4 weeks, 3 months, and 4 months post-impact. So it kind of is differing a little bit the farther we get away from that pandemic period. And our more recent analysis is looking at trying to get away from hurricanes and summer weather events. We wanted to look at a winter weather event. And so we looked at the 2021 events, which was kind of a cascading disaster. So you had the really, really cold temperatures and snow, which was really unprecedented for Texas. And it resulted in a massive power grid failure for that state. A lot of infrastructure damage, pipes bursting, long-term impacts. We wanted to see, so what are the impacts mental health-wise for this disaster? And then we wanted to look at a much longer time period. So we've been looking at things for very short time periods, 4 weeks, 6 weeks, up to 3 months for our last one. And this one, we went up all the way up to 11 months, as long as we could, to see what the impact was mental health-wise. And again, this was that huge winter weather event that pretty much hit the Southeast, but had the most devastating impacts for the state of Texas because of that electrical power grid failure. And we used, again, FEMA disaster declarations as our method for defining exposed versus non-exposed regions. And again, we're using a combination pretty much here of individual and public assistance. And so we used two methods. So we used an interrupted time series analysis, as well as a difference in difference. We also did some segmented Poissons, which I won't show here. But overall, we saw an increase in all conversations and thoughts of suicide. These increases, particularly for all conversations, were generally more pronounced the further away you got from the event. And then for stress and anxiety and depression, it was more time specific. And depression actually had notable decreases post-storm. They weren't significant in all models, but there was a decrease there. And so, yeah, interesting to look at this in a cascading disaster type framework. We also followed it up with a difference in difference analysis using a newer method, looking at multiple time periods. And again, with any text, we saw increases throughout the time period, but particularly with the context of the AREMA and the DID, the longer time periods were more pronounced. And then thoughts of suicide was another one where we saw significant increases. And so these two outcomes, and the thoughts of suicide is interesting because it's one of the more severe outcomes, and it's considered triage a little higher than some of the other outcomes. And one of the last things, so getting away from these climate disaster, one of the last things I'll talk about in the context of mental health and climate is high temperatures. So I've done a lot of work in this area. We were doing a lot of work with maternal health and high temperatures, looked at heat-related illness. We've looked outdoor occupational high temperatures. But again, if you're interested in that, I'm happy to talk about that. But today I'll just be talking about it in the context of mental health. We've used a couple of data sets to look at the mental health and temperature relationship. For some reason that's unknown physiologically, typically when we see high temperatures, we see increases in suicide, increases in emergency department visits with mental health, and this has been observed worldwide. We want to see if we see similar trends with crisis outcomes. So this has never been done before. This is one of our earlier publications too. And we looked at different urban areas from 2013 to 2017. And we compared it to daily maximum and minimum temperatures. We were using a distributed lag nonlinear model, quasi-Poisson, to investigate it. Yeah. And so overall, what we noted, so for certain areas, like this is the example of New York, this is our distributed lag nonlinear model here, looking at the warm season, the cool season, and then across both seasons. We see for New York at really high temperatures, we're noting increases in crisis outcomes. So the increases in crisis text line usage, and they're pretty notable. However, when we looked at other areas like Atlanta and the southeastern US, we don't see significant increases, which is interesting. So to me, it seems like areas with less temperature variability, there's less of that signal. We've also investigated this within the state of North Carolina. So this is looking at Buncombe County, and we've compared it to other counties in North Carolina, and the counties with less less temperature variability have less of a signal. And to me, I know with some of our heat-related illness work, we've also noticed that, for people who are more acclimated to heat, we see less of a signal. That less of that dose response you'd expect, that J-shaped or U-shaped curve. And perhaps this is what's occurring here too. And this was one of the first studies to explore the relationship between temperature and crisis outcomes. Here's some of our other plots using the distributed lab nonlinear model. We did see a nonlinear J-shaped relationship between temperature and the crisis texts that were observed. We saw significant relationships across most of our cities, with the exception of Atlanta in the southeastern United States. And we've kind of carried on this work, looking at it for North Carolina using some of our ED data, emergency department data, and coding it for different outcomes. Just looking at mood behavior disorders, we see here in the mountains where the Appalachian Mountains are for Western North Carolina, we see more of a heat signal. But with the coast and the Piedmont, which are, more acclimated to heat, they experience high temperatures more regularly, we see less of that signal. So it seems like we're seeing similar trends across the two data sets when in regards to temperature variability, but definitely more work needs to be done there. So thinking about next steps, so that's just like our first few aims of our NIH grant, but we want to get more at understanding how resilience and underlying place factors influence these outcomes. Some of the metrics, so again, I'm a geographer, some of the metrics we're interested in is looking at racial segregation or income segregation. Here's a map of the ICE metric, index of concentration extremes, which has been used by Krieger a lot, and looking at how this affects the ability of mental health post-storm, pre-post-storm. And so that's a direction we want to go. We want to look at like some factors like green space, a little bit more in temperature, and try to understand what are some areas, what makes a community resilient to some of these mental health impacts and what doesn't. And that's the direction we're headed into the next year. Another area is the green space. So we've done a lot of publications looking at green space and mental health. It's really interesting. This is not with the crisis text line data, but with the hospital administrative data. We've looked at public green space quantity, green space accessibility and quality, and how that impacts mental health. In North Carolina, we're seeing like some really interesting gradients across like rural urban areas. So the impact can be more pronounced. Accessibility is more important in some locations, whereas quantity is more important in others. And that's been an area we're trying to develop more, is understanding what type of green space. Is it quality? Is it being accessible? And how that influences mental health. And I think this is a great opportunity for a low-cost intervention. It's just introducing green space. We found effects with green space in mental health, as well as maternal health. And so that's an area we're also trying to develop further. And then some next steps too is we want to think about how do we approach these concurrent and cascading disasters. So climate change is amplifying some of these large climate events. We also have social events. This is the diagram that FEMA and SAMHSA they use to kind of understand the well-being of a community after disaster. They have the pre-disaster, the impact, heroic, honeymoon, when the community comes together, and then the disillusionment phase. But this framework is really based off a single disaster. It's not known how community well-being behaves across multiple disasters or these different types of disasters. And so that's an area we also are trying to get more understanding on. And then, how does the effect of disasters affect different populations? After disaster hits, there's always, it's been well established, there's increase in domestic violence. With crisis text line and some of our other data sources, particularly crisis text line, we can look at specific population like sexual gender minorities and see how they, what's their mental health pre-post disaster. We can also look at lower income communities of color. We wanted to zero in more on some of these demographic information we have. We've yet to do that yet, so that's definitely a next step we're trying to head in. And then ultimately, our big goal is, so we've been leveraging this data source. It's real time, it's really rich information, but wouldn't it be great to use this as a scalable crisis intervention post-disaster? It can fill the gap during this time period. And also, so it's a low-cost means to reach adolescents and to fill that unmet mental health need. And then from an epidemiological perspective, perhaps it can provide like real-time surveillance. So you can kind of get an idea of community well-being in real time during this disaster. So that's kind of the next step, is taking this information and trying to translate it into an intervention. Right now, crisis text line, they're focused on other things. They haven't really considered their intervention for these disasters. And some final remarks. So yeah, we have the potential. All this is real time. We have the potential for real-time mental health surveillance in space-time. We're generally seeing large significant increases in suicide ideation and stress anxiety after disasters. Some of these we're seeing more severe outcomes at some of the shorter intervals. Across disasters, it seems like social stressors seem to be the largest driver of crisis events. And we're trying to still discern how concurrent or cascading or univariate events, how that affects mental health across these different time periods. Also, some of the next steps we're trying to head in, we just got 2 R3 grants funded to look at maternal health. And so we have a lot of work gearing up for that. I mentioned that just in the hopes of collaboration. This is my email right here. I'm always would love to collaborate with others. Definitely part of a team. Dr. Jen Runkle at NC State is the dual PI. We also have psychologists, Kurt Michael and Marty Thompson, who provide all that expertise. I'm a geographer. And then, I'm at a primarily undergraduate institution. So a lot of this work is driven by students. So all these students are also listed below. So thanks to them. And a big thank you. I really appreciate the opportunity to present to all of you. Would love your input and a chance to collaborate. I'm also in the Appalachian Mountains. Here's a picture right here of Boone. And I think there could be a lot of, collaboration. So thank you for your time.
Thank you so much. That was fantastic. So glad that you joined us today and shared their very exciting climate and health research with us. So we do have questions in the chat, and now we'll take time to answer questions from the audience. So if you have a question, please put it in the chat and I will help facilitate to Dr. Sugg. So we have one from Dr. Hahn, who's put this in the chat. Can you talk more about the crisis hotline itself? Is it only reactive? Or is there a proactive element in which a caller gets a follow-up call?
Yeah, so right now, my understanding is there's no follow-up calls, so it's only reactive, and that the youth or the texter has to text in. But it's widely disseminated. They have a lot of partnerships. It's used. I asked my students; they all know about it. So it's well used among this population. But yes, it is reactive.
And then how does this nonprofit receive funding?
Oh, yeah, I know they were funded through the Robert Woods Johnson Foundation. I'm not an expert on where they get their funding, but they get it from a couple different sources, is my understanding.
And did you mention, how do youth learn about this? What's their primary advertising? How do people know to use this hotline, and how is it advertised?
Yeah, so I think it's advertised a lot on social media. So
Okay.
Facebook, TikTok, a lot of counselors will promote it during schools. There's partnerships with school systems. They have a strong part. One of the reasons we have such great Indigenous American coverage is because they have a partnership with a couple of those communities too. And so it's pretty widely used. It's been around since 2013. Like some of the earlier data, it's kind of spotty, but now it provides fairly good national coverage, I would say.
All right. Can you talk about how people can access it? How did you work with them to access their data and, be a partner?
Yeah, so I feel like I annoyed them enough that they finally said, "Who are you?" And I'm like one of the first people. I was there from the beginning. I feel like they've gone through it's a nonprofit, so they've gone through a lot of iterations. But Yeah, I feel like I bothered them a lot. I know that's not a very good, very professional answer, but yeah, and they're great. They have a new research team they're working with. But yeah, it's gone through a lot of iterations.
Got it.
And yeah, I kind of bothered them enough. And we
That's-
we have a good thing going. So I think
Yes.
they see some potential there. So
That's excellent.
Yeah.
That's excellent. And I agree with you. I think there is lots of potential with the geospatial analysis that you do and the climate initiatives and future research that our faculty have very strong interest in doing.
great.
So I'm so glad everyone had a chance to meet you today. There are a few more questions. Let me go through. Are there platforms that can be developed to help certain populations capture the data? And I'll let Chanel from Louisville elaborate if you'd like to. Yes, you can unmute and follow up with that question. I see you're unmuted, but I don't hear you if you're.
I can try to answer it too.
Okay, great. Go for it.
Yeah. So again, I'm not like a crisis. I just use their data to do. I'm a researcher, but my understanding is, for certain organizations like universities or big organization in Louisville, you can partner with them and they will give you data like a dashboard. They will give you a dashboard to understand like
Okay.
what the trends are for your community. So I believe I don't know if they still have it, but they used to have that, some sort of community partnership program. Hopefully that answers your question.
I believe it will. We'll let the individual chime in. So another question. It looks like you are partnering with NC State. Who was the partner at NC State?
Dr. Jennifer Runkle. So
Runkle. Okay. So we have this event here is hosted by an NIEHS Environmental Health Core Center, and NC State has a core center. And I'm wondering if the individual that you're working with is also part of their core center.
Yeah, I think she is. She's kind of unusual in that NC State has a climate center at NOAA, NCEI in Asheville.
Okay.
So she's there. And so she's like the environmental epidemiologist for the climate people. But I think she does partner, but I don't know how much at the P30 Center at NC State. But yeah, we're in the mountains. I feel like we're kind of, almost like a distinct state from everything going on in the Piedmont. So, yeah.
Great. And Dr. Rashid, you have a question in the chat, but if you're able to unmute, you can ask it directly. I like dialogue with the speaker. You can dialogue yourself directly, one-on-one.
Hello, Maggie.
Hi.
Yeah, I really enjoyed your talk, but I did have a question. When you showed your social stressor data, you commented that the COVID-19 pandemic and the 2020 election, there seemed to be some stressors, but less so was the George Floyd murder and the Black Lives Matter protests. And I'm just wondering if you thought that was a limitation of your study, or do you really think that, it wasn't that stressful?
Yeah, I think it's a limitation of the study. One population that I'm not getting we don't get good representation among is Black African American. So it's probably, that's what I find with this data set. But I bet if you used other methods, more qualitative methods, other data sets, you would find it something different.
Okay, so do you think if more Black people were included, you would see the increase, because you still have the kind of the distrust issue there, right? Like, are we really going to call a hotline? Yeah,
stigma. Yeah. When we wrote a grant trying to do that, trying to address some of, we wrote with a colleague who was an expert on this area, mental health stigma among Black youth, trying to address that issue. It didn't get funded though, because there is a lot of stigma and it can be hard for them. They don't we're seeing underreporting among this population. So it's obviously not being reached, even though it's very much needed. That would be an area I definitely would love to see more funding for. We just haven't been successful in that.
All right, thank you.
Thanks.
Great. And I see our Louisville attendee is in the room with their hand up.
Can you hear me?
Yes.
Okay, awesome. My name is Chanel Helm. I'm the strategic core lead organizer of Black Lives Matter Louisville. I'm also the state consultant for Sister Song, so definitely interested in the maternal health aspect as well, because I think we've seen that not only just within the US, but outside of the US, particularly around the equator countries where that comes into play with climate change. But I'm definitely interested in how, and as a community organizer, I kind of can support some of those techniques to get to those populations, especially Black and Brown, to give input. I agree with Rashad that the trust is not there. So it does kind of look weird if folks who aren't from that culture come and ask for questions or, hey, give this information here, because a lot of times it has led to incarceration, or it's led for people going into institutions, particularly mental health institutions, before anybody can figure out or actually get information about what is happening. So that's why I asked if there's a platform that's being developed that could support gathering the data. Folks like myself and others who live in these communities could actually gather that data, because I can tell you firsthand that, folks are definitely building that out. We went to Louisiana after, I can't think of the hurricane that was down there in 2017 or 16. And you saw how folks were thinking and what they were trying to do, but also like Dr. Rashid brought up, and I want to mention that 2020 was also started off with like this very grandeur idea of war, with the US going back and forth with Iran, and then into the pandemic, and then into the uprisings of 2020, where people were very unsure of what was happening. And what we saw in our communities was something that was very different than we were seeing in other communities, where fear and the reaction to what that fear might be had looked like. So that's why I was asking if there was a platform that could be used, because I'm very cognizant of what it means for someone who isn't from the community to actually grab data from folks within a particular population.
Yeah, I'm not sure of a platform used beyond, like, they already have this existing platform and they disseminate it. I like agree. I just wanted, this is not your question, but I did want to highlight that I didn't present on it, but we have been publishing on maternal mental health. And we're seeing, for some of those less, we're seeing a lot of maternal mental health. I mean, compare it to temperature too. We see, a lot of Blacks are having, women are having really, really severe maternal mental health outcomes. And they aren't being captured in the less severe outcomes. And we're also noting a trend with temperature too, which is, just something else within the context. But yeah, as far as the platform itself, Crisis Text Line, I'm not sure. I don't think they're working anything related to Black people, but I know it's an area we've tried to get funding for, and I would promote. I know they would be very interested in it.
I'm just going to jump in, and because I'm a geographer as well, so I just wanted to say hi. And really enjoyed your talk, and we're doing. I was just working on some similar analysis with a student, master's level student, who was interested in respiratory hospitalization after severe flooding. And I was glad to see that you had done something similar to what we had done in looking at the FEMA designation as like sort of a marker for maybe this flood severity or frequency, right? You can see, kind of count those up and how frequent they are over some number of years. I saw you were using some spatial scan statistics at one point. I saw one of those little maps that I've made before as well with circular scan windows, and that's kind of what we were using in that analysis. I'm not as familiar with some of the other methods you mentioned, so I'm definitely going to look those up, and you may hear from me because we definitely want to look into this, this sort of thing more in the future, like Dr. Haynes was saying. So again, just want to say hi and thanks again for the talk.
Yeah, it'd be great to talk SAT scan statistics. And I know the NCEI group, the NOAA group, they're working on, they're trying to create more novel flood metrics if you want to move beyond the FEMA disaster declaration.
Yeah, that would be
That's
great.
kind of like the easiest thing to do. The FEMA, it's like the good first step, but it has some bias in it at the county level. So, yeah. So follow up.
Thanks.
Yes, this was excellent. I have lots of questions, but we are at near to a time, so we want to be cognizant of the hour. Are there any more burning questions from the audience? If not, we want to thank you, Dr. Sugg, for joining us today. This was absolutely marvelous.
Thank you. Thank you for your time.
Thanks, everyone. And thank you for your participation. I hope you'll join us again. Thanks, Maggie. Thanks, Erin. For doing that. I had
glad.
A big noise.
Thank you, came.
Huge noise in my house, and I had to stay undone or unmuted or whatever. So thank you very much. That was so interesting.
Oh yeah, thank you.
So I had never heard of crisis text line, and what a novel data source. The reason I ask about the reactive is, or the proactive is really important. So you say that, let me just ask you really quick. So, and I see Bev still on, as a nurse, she probably has the same question.
Yeah, no, that's great.
So it concerns me obviously that people call in and they're suicidal. And then you said, but then if they are suicidal, they refer them right away. Is that what happens?
Yeah. So in a small portion of cases, they'll do an active rescue. They'll send EMS there.
Oh, okay. So they have this but you have no way to capture what happens to somebody because
I have active rescue information if they, but that's a really small subset. It's like less than 1%. It's an imperfect data source. The real-time components from a climate perspective is kind of
oh no, I mean it's great, but I wonder, and I also serve on our IRB, so my question identifiers too, like how did you get through an IRB? Well, what are there any did you even ask that? I forgot if you asked that question. Are there identifiers in this at all?
It's de-identified, so
okay, so you don't know even what their zip, but what kind of place data do you have then? Zip code or?
I wish I had zip code. I have the area code, and sometimes I do like a population weighted.
Oh, a phone number area code.
And then they have the zip code data, and on their side, sometimes they have the zip code data for like that survey, that 25% of them, they have zip code. They've tested my methods to see if I did a pretty good job